So revascularization, what does revascularization mean? If patient, the heart, a particular blood vessel supplying a myocardium of the heart is completely obstructed, that myocardium is not going to receive any amount of blood supply and it would have undergone necrosis already. On the other hand, you have another myocardium which is partially obstructed, maybe 90% obstructed. So when you are exerting alone, this myocardium is not able to receive sufficient amount of blood. So such a time patient is going to develop anginal symptoms and there is maybe 90% obstruction of this blood vessel. So by clearing this obstruction in this blood vessel, you are going to try to improve the blood supply to this myocardium, thereby you can prevent anginal symptoms. That is the usage of revascularization in a patient with chronic stable angina. So it is not routinely indicated in all patients, but patients having higher risk factors, refractory to all the measures to control angina, we can prefer revascularization. And urgent revascularization is not needed in case of chronic stable angina. So you don't require urgent revascularization. So there are two techniques when it comes to revascularization. One is percutaneous intervention and the other one is coronary artery bypass grafting. If you take whatever I was explaining before, I told you 90% occlusion is seen. First, we have to see how much occlusion is there. For that, we can use a coronary angiogram or you can use a CT angiogram. Coronary angiogram is invasive, a CT angiogram is a computed tomography technique, hence it is non-invasive. So you have done this and you have noticed that patient is having a significant obstruction, you want to clear the obstruction for particular reasons. Then you can decide whether you want a percutaneous intervention or a coronary artery bypass graft. So what is the difference between these two? You take, there is an occlusion, for example, you can see here a potential cause for rupture and thrombotic occlusion. There is a plaque here and it is an unstable plaque. You have visualized it during coronary angiogram, for example, and there was another unstable plaque over here and this unstable plaque was causing a limitation to the flow. It was like this. Okay, very minimal flow was going beyond this lesion. So such a plaque has to be treated first. So what you will do when you prefer to do a stenting, so this blood vessel is having two lesions, one is here, one is here. This is the lesion that you will want to treat first because this is the lesion causing maximal obstruction. So you will put a stent here. But this lesion still remains. So in future, if this plaque becomes ruptured, it can enlarge and cause another flow limitation in this patient. So though you are seeing two lesions, you are not going to stent both the lesions immediately. Multiple such lesions will be there in patients with ischemic heart disease. So you will take a choice of which lesion is flow limiting and you will try to stent that part of the coronary blood vessel. So this is what happens in case of a patient with percutaneous intervention or stenting as we call it. We have bare metal stents, we have drug eluting stents. So during stenting, we are stenting a flow limiting lesion, ensuring proper blood supply that passes beyond that lesion. In case of coronary artery bypass graft, similarly, if you have two lesions, you have one lesion which is flow limiting, very minimal amount of blood is flowing beyond this lesion, and you have another lesion which can rupture in the future. If you are able to bypass these two, so patient is having a normal coronary artery, you are creating a bypass from here to here. Okay, you are diverting blood from proximal through this bypass graft to here. You have bypassed both the lesions. So even if this ruptures in the future and is going to cause an flow limiting lesion, this bypass is the route through which the myocardium will receive its blood. So you have bypassed two lesions which are there, some lesion which is currently flow limiting and some lesion which can in future become flow limiting. So you are treating lesions which are not clinically significant even at that point of time. Thereby CABG, if we think about it, it is more beneficial in patients with multiple lesions. But considering that coronary artery bypass grafting is an invasive procedure, the thought process of rehabilitation, the complications of the procedure have to be kept in mind. That is why PCA is very commonly being done and patients are preferring PCA rather than coronary artery bypass grafting. The recovery takes a very long time. Side effects associated with the open heart surgery still exist in a patient with coronary artery bypass graft. So the difference in the technique I have explained to you.